Hi everyone, my name is Bella and I'm going to be presenting to you my EBP Part 5 project. Some background information, my project is on pressure injuries and hospitalizations, and I chose to do this because when my grandmother was in the hospital, she developed a pressure injury and it caused her immense pain and discomfort. And along with the practice that we have had at our medical surgical units, the patients had high incidences of pressure injuries, and you could tell that was causing them a lot of distress and discomfort throughout their day. And they're already in the hospital, bedridden, and it just kind of makes their whole experience so much harder, and healing becomes so much worse with time. So, why are pressure injuries a problem? So, as you can see here, this is kind of a diagram showing how pressure injuries work. We have our four different stages: stage one, stage two, stage three, and stage four. And by the time you get to stage four, the wound has already went all the way down from the base of your skin into your bone, causing an exposed area. This can expose different pathogens to patients, and they're putting them at risk of developing sepsis. They're also very difficult to heal due to different locations. A very common one is on the sacrum, and when patients use the bathroom, bacteria to enter, some fecal matter to come in, and makes it much more difficult to heal. And when you're already getting an injury that's so deep into the body, it can be really difficult to get that back to normal and cause a normal skin barrier. So the PICOP question that I chose and developed was: in bedridden, hospitalized adults, it's implementing a 1 to 2 hour fixed repositioning schedule compared to the non-standard practices, reduce the incidence of pressure injuries during hospitalization. So let's break that down. The population we're looking at is bedridden hospitalized adults, as stated in bedridden hospitalized adults. The intervention we're looking at is the 1 to 2 hour fixed repositioning schedule. So this is the turning situations that we do as nurses to help our patients prevent these ulcers from developing. And our comparison that we're looking at is the non-standardized practices. So a lot of places don't have a standardized turning schedule practice. And then our outcome is we're looking at the reduction of incidence of pressure injuries, which during this time of hospitalizations. So on this slide, I'm going to walk you through some of the major research strategies that are used across the literature, examining the fixed turning intervals and pressure injury prevention. Although these studies are focused on the same goal and same topic of preventing pressure injuries, they use very different methods, but together we give us a well-rounded understanding of the clinical issues and the educational, technology, and ethical perspectives involved. So I'll begin first with this top study here. This research is using a systematic review and meta-analysis, which is considered to be one of the highest levels of evidence. In this type of study, the authors don't collect new patient data, but they do use multiple research databases from previously published trials. So their goal here was to synthesize research involving randomized and quasi-study experimental studies related to the repositioning practices. So with pooling these different results from the different clinical trials, they were able to determine whether repositioning is deemed overall effective. And the findings here clearly support that repositioning is a beneficial strategy for reducing pressure injuries. However, the review had a major limitation in that they weren't able to determine a precise turning interval. And because of the heterogeneity of the study, they were not able to identify this interval, such as 1 to 2 hours, or even if it should be longer, to be the most effective way to prevent pressure injuries. So this review, shows that the intervention of turning is very valuable, but it also has a lot of gaps that need to be figured out more into the evidence. And then the second study we have here is a cross-sectional survey of different nurses. And so instead of evaluating the clinical outcomes or patient data, the study examined the nurses' practice, knowledge, and education related to repositioning. Their goal here was to understand how consistently repositioning is performed across different facilities, and what barriers might be preventing the best practice to limit these repositioning instances or pressure injuries. So what they found was relatively variable, that facilities differed widely in how frequently they turned their patients and how well that the nurses understood pressure injury prevention and how that consistently turning schedules were followed. This is very important based giving like the best clinical judgment can be ineffective and if not carried out correctly. So this idea of turning patients can be seen as ineffective if they're not actually going through and turning the patients properly. So the authors in this article emphasize that there is a need for improvement and more education and standardized training across different facilities to address and practice these gaps. The next group of studies here kind of follow the same understanding in different technological advances. So there's two different groups that kind of did the same thing, but they engineered different forms of sensor-driven methods. So instead of just relying on surveys or literature reviews, they decided to make these sensor-based systems to detect pressure points to guide individual turning schedules. So these studies incorporated pressure mapping mats, artificial intelligence algorithms, or automated monitoring systems that generated personalized recommendations for the patient's repositioning. The early results of these studies suggested that the technologies could help the nurses reduce workload and improve turning adherence by providing like immediate real-time data. But the studies also pointed out limitations that included accuracy issues, calibration challenges, and the need for further development before actually being used in a clinical setting. The emerging technologies, however, did show some promise, but they are not quite ready yet to replace traditional repositioning practices, as there's still lots of flaws that need to be worked out. This last study here used a qualitative ethical approach. And so rather than collecting numerical data or testing technology, they decided to analyze the implications of a rigid 2-hour turning policy and looked at how that affects the patient dignity and a harm perspective. Their analysis argues that the strict schedules, when applied universally, may cause unnecessary discomfort and do not always align with patient-centered care. And their findings call for more flexibility and individualized decision-making instead of relying on a routine or ritual. So together, these studies all show that these repositions remain essential, but the research strategies highlight different gaps in knowledge, inconsistency, and in nursing practice, and that the emerging role of technology can benefit patient individualized care. They also focus on the ethical barriers that are associated with this, but they were mostly just recommending that sometimes consider the patient dignity as a means of ethical standing. But there is a lot of strong support for repositioning as a prevention strategy, but there is mixed findings on the optimal timing, which was the biggest gap in research found. But the growing interest for personalized technology continues to become popular. So a big question is like, how can we improve in the clinical practical significance of the whole studies and the findings? Clinically, the evidence reinforces that turning practices in patients are essential, even when we lack a perfect interval. Repositioning will redistribute pressure that protects the skin integrity and reduces overall patient harm. The inconsistent nurse education, though, and facility practices will weaken the effectiveness of the sample of the interventions. The literature will also highlight that the rigid turning schedules may be less effective than patient-specific plans. The emerging research for sensor-based systems suggests that individualized timings may eventually become more precise and more feasible and reduce the overall workload and burdens of improving adherence in the nursing career. However, this does still need to be worked on and getting all the bugs out of the system. And how can this information improve practice and patient outcomes? There are several implications emerging from these studies. Facilities should enforce consistent nursing education on pressure injuries and prevention to reduce the variability in practices. This is highly important as we are not taught significantly in nursing school about pressure injuries. We only had a few days or a week of a module, so it would be really nice to have more hands-on skills in preventing pressure injuries and more just a general education. The units may also benefit from adopting a more flexible patient-centered repositioning plans rather than just relying on the rigid 2-hour schedules, as this can help the patients and make it easier on the nurses in the long run. And then We also should start investing in emerging technologies like looking at pressure sensing systems, which may eventually allow nurses to customize training frequencies based on patient risk factors, bodies, skin status, and looking at the real time pressure data. And incorporating the ethical considerations such as respect and patient comfort, sleep, and dignity can also ensure that the repositioning is both protective and compassionate. So, was my question answered? It's a little iffy because the current literature does not provide a definitive answer about whether a fixed 1 hour or 2 hour interval is superior by preventing pressure injuries. But the systematic review confirms that there is a benefit in repositioning in general, but due to the different study designs, varied intervals, and a lack of high quality comparative trials, we cannot conclusively determine which fixed interval is best. So, therefore, the PICOT question remains partially unanswered, not because of repositioning is ineffective, but because the research comparing the specific intervals is insufficient. But overall, the evidence supports that the repositioning as a critical practice highlights the gaps and still needs to be addressed, and the points towards a future where individualized care and improved education will lead to better patient outcomes. Here are my references for this presentation, and thank you so much for listening.